That is all I got. If I'm pretty informal, so you can pretty much ask me anything. Yes?
Recurrence. This is not necessarily a thing that's going to end it permanently. If it wants to grow back, it grows back.
Well, it depends on the lesion, depends on the diagnosis. It has obviously varying success rates depending on what type of lesion we're talking about. So I can actually ask you if there's any specific diagnosis. What are you talking about?
I had an MRI. I had gamma knife also after surgery and all, and still blew back.
For what?
Anaplastic astrocytosis.
So yeah, so it's not uncommon.
It was reduced so that we couldn't use the gamma knife.
Yeah, so the gamma knife serves as an ablative tool. It will only treat what we target it to treat.
Right.
So if there are cells away from the site that we treat, obviously they will continue to grow. Again, anaplastic astrocytomas and glioblastomas, the treatment is standard daily radiation over a course of 6 weeks to treat. The gamma knife plays as a role for patients who have recurrence. In general, the data for stage 3 and stage 4 gliomas is that 30% of patients will respond. And it's not a high number, and I know, and that's because, again, there are cells that you can't see that will grow. But in those patients that respond to radiosurgery, they live longer. Survival is improved, quality of life is improved. So if we can, help 30% of patients who may not have good alternative options, we're happy to offer it. But again, we certainly don't promise that there's a 100% success rate with those types of situations because, as I said, there are cells that you can't see with these types of tumors.
I do have to say, the day after I had the gamma knife, I felt better than I did the whole year before. I walked fine.
Yeah, patients tolerate this very well.
It was as if it was gone.
Yeah, patients tolerate this very well. In fact,
I just felt totally different.
That's great. And again, I think it's difficult to say whether it benefited you because, as you said, it came back.
Right.
But, at the same time,
It gave me another time, gave me some more time so that we worked out more treatment.
That's great. That's great. And that's what, we do with stage 3 and stage...
It did go away ultimately.
Wonderful,
So.
wonderful. For stage 3 and 4 gliomas, that's kind of what we're looking at gamma knife to do, which is to buy some time to look at other systemic therapies that could potentially be available, other experimental drugs that might be available, and again, to improve quality of life. If there's some type of neurologic deficit that we can help you improve, that's the purpose of gamma knife. That's why we do it. We do it in patients who may not have a surgical option. If patients have tumors that are deep-seated, that have had surgery already, that have had radiation already, where another re-resection may not be safe to do, we look at gamma knife to help us in this situation.
I was just going to ask you to speak to the difference. The people use gamma and cyber in the same sentence, and they're very different without
right.
the frame and.
Absolutely. So, kind of a new thing that's been going on that you might have heard about is something called frameless radiosurgery. And frameless radiosurgery sounds very appealing to patients because it doesn't involve us putting these pins in the head, and so patients don't need this. They have a mask put on, much like the way Dr. Weiss had mentioned we do our daily radiation treatments. So CyberKnife is a mechanism of delivering frameless radiosurgery. It uses basically a radiation machine on a robotic arm. That robotic arm has 6 degrees of rotation, so we can move around in space, and it looks kind of cool. It looks like a RoboCop kind of device that can pinpoint a lesion using a single beam, so it treats in multiple different directions. It's a nice piece of equipment. It requires a huge amount of quality assurance. In fact, there was an academic center in San Francisco that actually shut down because of quality assurance issues where, the machine was actually creating a lot of toxicities because of bad aiming, for lack of a better term, in terms of quality assurance, because it's a bear to figure out, you've got this thing that can target a lesion and it can move in all these different angles. How do you ensure that it can pinpoint a single point in space? And so it can be very accurate and it can be very useful, but you got to make sure that the quality assurance is being done on that machine. So the problem with frameless radiosurgery, and we've done frameless radiosurgery with tomotherapy, and we still offer it to patients in situations, but the problem with frameless radiosurgery is that you have to do one of two things. You have to put a margin around the lesion you're trying to treat. So if you have a lesion, you kind of have to put a few millimeters around it to ensure that any level of small movements in the head that could happen without a frame are accounted for. So typically when we treated with a frameless radiosurgery device, when we treat for example, a metastasis, we'll put 3 millimeters around the lesion to make sure that there's any type of head movements. You know, I skipped let me see if I can show it to you. I skipped one, I skipped the slide kind of thinking it wouldn't be that relevant, but it may be. Let me see if I can get to it. So here's a slide that I kind of breezed right past and said for the sake of time I wasn't going to talk about it, but since you asked. Here's a study that was published in a major medical journal in radiation oncology where they kind of followed a patient's head movement using a frameless radiosurgery device. And so patients were fixed using basically a mask the way Dr. Weiss had shown you a picture of, and they followed head position. And you can kind of see each of these ticks represent what happened over a period of time, and this is in centimeters. And you can kind of see in ant post, that means front to back, left to right is obviously obvious. Inferior superior means up and down. And so the square, the triangle, and the circle represent different planes of movement. You can see over a period of time, you see these motions. And again, these are in centimeters. So if you talk about a patient who has a 0.2 centimeter or 2 millimeter head movement and you're trying to train a pinpoint device, you got to make sure that you put either a normal amount of tissue around it and that your QA is up to par. So typically with a frameless, you have to make sure that you account for this variability in head motion that can happen. And so, you know, you talk about the CyberKnife and they'll say, well, you know, we have these cameras that turn on every 10 seconds. Now, imagine the amount of head motion that I can do in 10 seconds. If anyone's got a stopwatch and I do this, ask me how many times I do this in 10 seconds. It can be pretty significant. So it is a reasonable device for some things, but for example, when you want pinpoint, you can't use it. For example, in some cases where we're just trying to treat a nerve like trigeminal neuralgias, I don't think there's any role for CyberKnife. So if you're looking for accuracy, that's only a fixed frame, single fraction treatment. Hope that answers your question. Yeah.
What if you sneeze?
You can't move. The head does not move. You know, we've seen that. Patients cough or sneeze, and the funny part is the body moves, not the head. It's kind of funny to see. It's your whole body shakes, but the head is secured in position. It doesn't move. Again, that would be different if you had a mask on and not a head frame. This is pinned. This is pinned. So yeah, you cannot move your head. You are, and you feel it. And so yeah, we've had people who had, you know, obviously patients who have lung disease or lung metastases, you know, have lung cancers, who have brain metastases, who have a constant cough. You'll see them cough. You'll see their body move. See them move their arms or you know, their chest, and the head is fixed. It's fixed. Yes.
Oh, is it in your life limitations for that?
I'm sorry?
Is it in your lifetime limitations? How?
Lifetime limitations. Yeah, you know, I don't think that we would offer you. Yeah, I don't think we would offer you radiosurgery to the same lesion 3 times in a row. I just think there's no data on it. There is data on 2 times in patients who have recurrent disease, but if you've had it twice to a single lesion, I don't think we'd offer it to you. If the lesion is extremely large, so if we had a 5-centimeter tumor, I think we're gonna, because of the way the radiation delivers, I think it may be a little bit beyond the size of what, you know, we could safely deliver. So we're talking about lesions that typically are under 4 centimeters. We push that, you know, limitation a little bit. We may go 4.5, even stretch 5, but we won't go much beyond that.
If you have multiple lesions, not one, how you can address it during your surgery?
Yeah, so we have treated multiple lesions. Obviously, we're talking about metastases, patients who have had multiple lesions in the brain. 10 years ago, we used to have a rule that said if you have more than 4 lesions, we needed to give you whole brain treatments because that's the only way to treat these lesions. There could be cells that are, that we don't see on MRI. As Dr. Weiss had mentioned earlier, that trend is actually changing. We've treated patients with multiple lesions in the past, as well as many academic centers have done so too. I think we're learning more and more that whole brain radiation therapy is not good. If we talk to our medical oncology associates who follow these patients long term, they'll tell us they have severe limitations in what chemotherapy they can receive afterwards, that they need huge delays in chemotherapy to kind of resume treatments just because they're tired, they're fatigued from the treatments. They complain about short-term memory. The extreme of whole brain radiation therapy is that there are patients who have developed dementia from these treatments. So we respect that, and so we know that there are significant cognitive impact on treating the whole brain the way we have in the past. We also know that Gamma Knife for radiosurgery can treat these lesions pinpoint, and we can do it over and over again. So for example, we've had a patient who had a malignant melanoma, who potentially, a lot of these patients, malignant melanoma is one of those lesions that don't respond well to standard doses of radiation. Oftentimes we give them whole brain treatments and they continue to grow and ultimately will pass due to brain death from tumors that grow despite what we throw at it. And in these cases, we've done radiosurgery repeatedly on these patients, and they've done well. These lesions are controlled because, again, we're not using standard radiation philosophy where we deliver daily treatments and try to impact the cancer cell and allow the normal tissues to recover in between. We're looking to ablate what's in its path, and that includes, tumors that are considered radioresistant.
Slide said you send patients home with a tapering dose of steroids?
Steroids. So, not everyone does that. What I do is if patients have not been on steroids for, prior to this and they're symptom-free, I may keep them on steroids for a week. And if I see them back a week later and they're feeling well, I just tell them to discontinue it. If you're on steroids for a week, you don't need tapering doses, so I just tell them to discontinue it completely. In patients who have pre-existing edema, oftentimes they're on steroids to begin with, and I may gradually decrease the doses. So it depends on the scenario. For example, I treated a benign lesion last week. I saw her back today. And she told me she couldn't stand the steroids because it was making her so jittery and hungry. She was gaining weight. And I just told her to stop it. She was on it for a week. There's going to be no withdrawal issues or problems with stopping it after a week course of steroids. But we do it in case there's any kind of flash edema or swelling that could happen from the high dose of radiation in that single fraction or single dose.
Question for both of you, speaking of the Decadron. Has anybody come up with anything better for the swelling than the Decadron?
Not orally. Nothing orally. Not intracranially and not orally. Yeah, it's not, there are IV things that you could potentially do that might be a little more effective, but that's all inpatient stuff. Yeah, everyone responds to steroids a little bit differently. It's a bear. I mean, it makes you resistant to, it makes you more susceptible to infections. Oftentimes you end up getting fungal infections. It disturbs your sleep, makes you hungry, may make you jittery. Affects your sugars, even if you're not diabetic. Sometimes if you're on it long enough, your blood sugars shoot through the roof. So we don't necessarily like patients being on steroids for a long period of time, but we also like to maintain patients' quality of life, so we kind of have to balance that out.
It affects the spouse too.
Yes, yes. It's the old, honey, are you awake? You awake? You awake? Oh, I was just checking.